Welcome, everyone. I'm Jeff Folloder. I am a passionate CLL and SLL patient advocate, and I'm also a patient. We are live with CLL Society's Facebook Live event, Ask Me Anything, where we spend the next 60 minutes answering your questions with a CLL expert. And we are so lucky to have Dr. Samir Parikh joining us today. There are no presentations, and we encourage you to ask your questions on the Facebook page if this is how you're joining us, or through the Zoom platform. This event is dedicated to your questions, so ask them early to make sure we get to them all. Before we begin, I've got a few disclaimers to share. Remember that nothing said today should be taken as medical advice. Any questions about your health and treatment, those should be discussed with your healthcare provider. The information that you post on Facebook will be shared on a public forum, so please do not post or share confidential information. So without further ado, Dr. Parikh, would you please introduce yourself for our audience?
Hi, Jeff. Thank you very much for that kind introduction. And I'd like to thank the CLL Society for the invitation as well. My name is Samir Parikh. I'm a hematologist at Mayo Clinic in Rochester, and I take care of patients with CLL. That's my primary area of focus. I've served on the medical advisory board of the CLL Society, and I try to do my best as I can to help educate our patients and do my part in helping them along their journey in CLL and SLL. So I'm glad to be here, and I look forward to the questions.
Thank you. We have a bunch of questions already coming in. The first few deal with vaccines, not necessarily the COVID vaccine. CLL patients and SLL patients are considered immunocompromised, and vaccination is a very important part of their healthcare regimen. So I've got this whole list in front of me. Let's start right away. If a person with CLL does not fully respond to the pneumococcal vaccine, how would you determine if it is something like primary or secondary immunodeficiency or from CLL? They're wondering because an immunologist might say give IVIG, and an oncologist might say no IVIG in light of no infections. What do you think?
Yeah, that's a good question. I think we typically don't measure responses to vaccination after routine vaccinations are done in routine clinical practice. So in research studies, we will give a vaccine, we will measure the response to the vaccine, and we will determine that of all the people who received the vaccine, roughly X number of patients responded, Y number of patients did not respond. And then we try and figure out what are some of the characteristics of patients who did or did not achieve a response and sort of extrapolate that information in the clinic. So I just want to be very clear in mentioning that when I recommend a pneumococcal vaccine to a patient, I do not ask them to go check a titer to see if the vaccine has worked or not. And that is the practical way of doing it, because most of the time it is not easy to get these titers done. Even if they are easy to done, it's very difficult to interpret them, because what is considered to be a protective threshold for an antibody titer is not very well established for a number of these infections. And we also have to remember that it's not only the antibody response by measurement of a titer. There are other aspects of the immune system, such as T cell responses, NK cell responses. These are other arms of our immune system that are all also working to try and help us protect against an infection. And those are most certainly not checked in routine clinical practice, and even in a research setting are very difficult to check for. And so my practical advice to all patients is that, look, you have to recognize that, as a patient of CLL, SLL, and even MBL, which is considered to be a precursor condition to CLL, we would consider all our patients to be unfortunately immunocompromised. So what can you do to protect yourself? I think number one, get yourself acquainted with the CDC's definition of immunocompromised status,
Mm-hmm.
and just bring this up with your primary care physician or your oncologist or your CLL specialist, that look, I am 50 years old, for example, and I may not fall in the greater than 60 or greater than 65 age group of patients or people in the US to get vaccination. from a general category, but because of my CLL status, I'm immunocompromised and I should receive, for example, the pneumococcal vaccine because it's not recommended for the general population beyond 60 or 65 years of age. So everyone should get that. The second thing I would mention is that you have to recognize your own risk, meaning if you have received no treatment for CLL, chances that you will respond to a vaccination, and you can take any vaccine, influenza, pneumococcal, shingles vaccine, COVID, etc., across the board are much higher compared to if you have recently received treatment. And so that is another thing, important thing to remember. The third thing to remember is that if you have received a vaccine and there is a booster dose or a second dose or a third dose that is recommended for that vaccination. So for example, the Shingrix vaccine, you need to do 2 doses at least 2 to 6 months apart. So please remember to take that second dose. Please don't forget that. Please mark it on your calendars because it's very important that you get that second dose. And similarly, for influenza vaccine, for COVID vaccination, et cetera, make sure you get your booster doses done in a timely fashion because those are important to keep your immune system up to speed to protect against infections. And just to round up that question of, whether you should get IVIG or not, or go to an immunologist, the way I would approach that is, if you are someone who has had little or no response to vaccinations, from the beginning as a child or, even as an early young adult, chances are that you likely have some sort of a primary immunodeficiency, if that is really the case, which is very rare in CLL, but we do see patients like this every once in a while. And I would routinely refer those patients to my colleagues in immunology, and I would ask them to help me treat this condition because to the person who asked that question, primary immunodeficiency meaning you really have a deficient immune system even before CLL ever existed is a very different condition, and you need to see an immunologist and pursue the treatment recommendations from them compared to a secondary immunodeficiency, which is secondary to CLL or CLL directed treatments, which is where hematology would get involved. And so if there is a confusion between primary or secondary, I would seek an opinion from my colleagues in immunology and get their input.
Sounds perfect. You hit every point that I think our listeners wanted to hear. You did mention the flu vaccine, and I know that as a patient advocate, I hear quite often, I'm not going to get the flu vaccine. It gave me the flu. I know that there's side effects. Could you explain to people what the side effects are of a flu vaccine and what's really going on when you get one?
Yeah, thanks, Jeff. So, I think that's unfortunately a question that we get in the clinic all the time. And so, I think it's important to realize that if you get a vaccine today, by the time the vaccine will exert its effect and its response and help you protect against an infection will likely be a few weeks before you will have the sufficient protection from the vaccination to be able to fight the infection. And so if you got a vaccine today and 2 days later you were symptomatic and you tested and you were positive for flu, it isn't because the vaccine gave you the flu, because you were likely incubating the infection even before you knew it. And also, it isn't that the vaccine didn't work, it just didn't have enough time for it to work. Now, if you don't, if you may get symptoms and you test for, flu a couple of days later after getting the vaccine and it tests negative, it likely means you have side effects from the vaccine. And those are unfortunately very common. And they can include fever, muscle aches, muscle spasms, injection site pain, just chills, etc. And you just don't feel, like it. And unfortunately, there is no real way to avoid or prevent them from happening. If you really feel bad, I think you can take some Tylenol, and I think that can help some of the symptoms. In many patients, we have heard that their lymph nodes will swell up when they have CLL that is untreated and they already have big lymph nodes to begin with. Again, those are temporary reaction to the vaccine that patients get, and they typically will go away in about 5 to 7 days. Now, the only other thing I will add is, and I don't know if this is necessarily true for everyone or not, but I for my patients who tell me, look, I have had bad reactions, etc., I will tell them, just clear your schedule for some time after the vaccine because you don't know how you're going to tolerate it. I will also tell them, don't take more than one vaccine at a time, although it's allowed. You could take both the flu and the COVID vaccine at the same time. If I have a patient who tells me I've reacted, poorly, I would say, well, maybe take one at a time. Don't take both. I don't know if it's going to be worse or not. Maybe and I'm actually indirectly maybe telling them to be miserable twice as opposed to just one time and be done with it. So I really don't know the answer, but I will ask the patient to make a decision.
That sounds great. Let's shift gears for just a second. Mike has sent in a great question. I'm going to ask his question and then add on a little something to it. He wants to know, what is the advantage of being UMRD as compared to being symptom-free and stable under therapy? So we need to answer his question, but we also need to explain to the audience what UMRD is.
Yeah, that's a good question. So UMRD basically stands for undetectable measurable residual disease. And so maybe I can spend a few minutes talking about this concept because I think this is a question that comes up all the time. So I think as cancer doctors, when we provide any treatment to a patient, our first question in our minds is, okay, we knew how much disease you had, we know how much bone marrow involvement there is, what the lymph node sizes are, etc., before we start treatment. And then at the end of treatment, we want to know how much benefit have we achieved from this treatment. You went through all this toxicity and coming to the clinic, getting infusions, taking pills, etc. And that benefit of the treatment can be measured in a variety of different ways. You can check blood numbers to ensure that the white count is improved, hemoglobin is improved, etc. You can recheck a bone marrow biopsy to see how much improvement there has been in the bone marrow percentage involvement of CLL. You can do a scan and see, has the lymph node enlargement receded? Is the spleen size normal? So these are what are called as the traditional criteria for response, and we would attribute a complete response or a partial response, etc., based on all of this information. Now, what has become apparent over the last few years is that we can now, with very sensitive techniques, try to determine even small amounts of CLL cells that are left behind after treatment. And this is what is called as measurable residual disease or minimal residual disease. And there are two very common ways of doing this test. One is called a flow cytometry study that can look for the presence of any residual cells in the blood or the bone marrow, or another sort of more sensitive technique called as clonoSEQ. And that's a test that is ordered by your physician and they send the blood off for testing. Regardless of the technology that is used, what has consistently been shown in many clinical trials is that if you are able to get to this undetectable MRD status, it is very likely that your disease will not relapse after the completion of treatment for a longer period of time compared to somebody else who had residual disease detected at the end of treatment. Now, the amount of residual disease varies, but the typical threshold that is advised by the IWCLL criteria is one CLL cell in 10,000 white cells. So that's sort of the number that we are looking for. Now, there are many caveats to this. So number one, even if you get to this undetectable MRD status, doesn't mean that there is no residual CLL. We know that there is much more CLL left, unfortunately, that we cannot eradicate. And unfortunately, that disease does tend to come back. But we know that if you are able to get to undetectable MRD status, the time it takes for that disease to come back is longer compared to somebody who does have residual disease left. The other caveat to remember is that we are measuring only the blood or the bone marrow when we do this MRD testing. We are not looking at the lymph nodes, which is another area of residual disease. And in some patients, that can be a harbinger of where the disease comes back. And so that, again, is important to remember. Another important reminder is that at the current time, we do not have evidence or data to suggest that if at the end of whatever fixed duration therapy that is administered, if you have residual disease, by extending the treatment or making any changes, to get you to an undetectable MRD status is going to influence outcomes. Those clinical trials are ongoing. So the way I use this information is I will give my patient treatment to get them to whatever best undetectable MRD status is. So it's a 1 year in the frontline setting or 2 years in the relapsed setting with any fixed duration therapy. So we stop, we measure residual disease, and then sort of have a discussion. Okay, fantastic. We got to the UMRD status. It's likely that the disease is not going to come back for several years. Compared to no, we do have some detectable disease. It's likely that the disease will come back sooner than later. However, we don't act on this information, at least right now, because it doesn't, there are no trials that show that acting on this is going to make any difference. Now, all of this pertains to fixed duration therapy, meaning I have started, the intent of my treatment is that I will give you a treatment that's going to be for a finite period of time. So for a year or 2 years. And these are typically venetoclax-based treatments, which are oral pills. The question posed was, what about giving a treatment that is oral, that is continuous without any stopping? And how does that relate to this UMRD status after fixed duration therapy? So again, there is a randomized trial that is actually looking to answer this question. It's called the CLL 17 study. It has completed accrual where patients get continuous ibrutinib therapy compared to fixed duration therapy with a couple of different arms. These results are not out yet. Hopefully in the next few years, we will learn more. So at the current time, either approach is fine. I prefer this approach if I can, because I know that with continuous therapy, there is ongoing financial toxicity, there is ongoing minor issues that can happen with blood pressure problems, heart rhythm problems, bleeding, et cetera, et cetera. And so again, you have to talk to your doctor and try and figure out which is the better approach. But I think getting to a deep remission, stopping treatment, and enjoying a treatment-free duration with the similar sort of duration of response without any evidence of disease is always a good idea in my mind.
That was awesome. And I was doing a lot of smiling and nodding because you talked literally about my experience. 8.5-ish years ago, I went through a fixed duration IV treatment for my CLL, and I achieved MRD negative status. And I had 6.5 years of rock solid, complete remission, did fine, and my CLL did come back. I'm still doing all the things that I want to do. We're keeping a watchful eye on watch and wait. The numbers continue to deteriorate, but I am very hopeful and very confident that the progress of medical treatment will continue to improve. Let's jump back into a couple of questions here. I know that there's an awful lot of very specific testing that goes on with CLL. There's the FISH, there's the flow. The question says, I was diagnosed with CLL in December of 2022 via flow testing on a lymph node biopsy. Blood work remains relatively stable. My doctor does not feel that mutation and deletion status need to be checked until treatment is needed. Should I insist on those tests even though I'm feeling well?
Yeah, that's a great question. And I think this all depends on your outlook and your philosophy in what you want to know and how much do you want to know. I think in general, if you don't test for any of these things at the time of diagnosis, including, so the diagnosis is typically established by a flow cytometry study, which is a blood test or a lymph node based test that will identify these CLL cells. Now, that is the bare minimum that you need to get done to establish a diagnosis of CLL. The vast majority of our patients at the time of initial diagnosis don't have any symptoms, have an incidental diagnosis because they had a blood test or they had a mammogram and a lymph node was enlarged that they thought was breast cancer and was biopsied and was found to be CLL, for example, right? So that is a relatively common way of identifying CLL these days. It's an incidental finding. Most people are asymptomatic and are feeling fine, and this diagnosis is obviously a shock to many of our patients. The vast majority of CLL, I shouldn't say the vast. I think it's a very heterogeneous disease. And what do I mean by that? In many patients, the disease remains stable over time. It doesn't change. Patients don't have any progression. They don't need treatment. And we simply watch and wait and observe. But in a substantial proportion of patients, and I would say roughly 25 to 30% of patients, the disease starts progressing rather quickly. And in a few years, we see patients needing therapy. Now, these tests called the CLL fish profile or the IGVH mutation status, etc., these are powerful prognostic tests, meaning if you get them at the time of diagnosis, and I have to be honest, at Mayo, we get them routinely for every patient because we believe that we have the ability by the use of these tests to be able to counsel our patients better as to what to expect. And so there is something called as the CLL International Prognostic Index. And so it's a calculator that bases this definition on 5 different parameters, including your age, the RISE stage on physical exam, what RISE stage you have, CLL fish, IGVH mutation status, and a blood test called as beta 2 microglobulin. And so these 5 parameters will allow us to classify the disease into low, intermediate, high, or very high risk of disease progression. And so what does this mean? So if we can classify your disease in low risk of disease progression, we know that in 5 years, roughly 20% patients need treatment. If the disease is classified in the intermediate stage, then we know that about 50% patients need treatment in 5 years. If the disease gets classified in the high risk status, it's roughly 75% patients who need treatment within the first 5 years. And in the very high risk, 90 to 100% patients need treatment in the first 5 years. Now, if you are the type of person who says, well, I really want to know how my disease is going to behave, how quickly is it going to progress, etc., then by all means, I think getting this information that's readily available is covered by insurance would actually be quite powerful because it is very important for a lot of people to know how is this going to progress, and I would be for one want to know how is my disease going to do. On the other hand, there are some patients who might say, well, it's fine, I'll just go to my doctor every 3 months, every 6 months, and we'll see how it goes, and that's perfectly acceptable. There's nothing wrong with that. I think the latter approach may be more meaningful or may make more sense in people, who are in their 80s, 90s, or have otherwise a limited life expectancy because of many other chronic medical problems, right? Why then, test for all of these things? Because, if you have other cancers going on or other medical problems, then it might not change how you would approach it. But for the vast majority of patients, we get all of these tests at the time of diagnosis.
Thank you very much for that. I think you hit all the points that our listener wanted to get answered. So let's talk a little bit about, okay, we've got the prognostics down, we've got the CLL diagnosis down. Philip says that he was diagnosed about a year and a half ago. His numbers have very gradually gone up, and no treatment at this point. No treatment has been given. At what point do the docs choose treatment, and can numbers continue to go up without the need for treatment?
Yeah, so let me answer this question, which is very important, maybe in a couple, different ways. So number one, this is a question that I get asked all the time is, we always hear that, find cancer early so we can fix it early. Yet here we are, we diagnose CLL and we tell you, go home, we'll see you in 3 months, right? So why is that? Why is that when we find cancer at such an early stage, do we tell our patients not to get treated? And that really boils down to the fact that over the last 3 decades or so, the CLL community, the researchers in the CLL community have tried to do clinical trials where they have randomly assigned early stage CLL patients who are otherwise asymptomatic into treatment versus no treatment. And what they have found consistently is that treatment at an early stage has not made our patients live any longer. Meaning that when a patient does have progression of disease, you're able to treat that patient and rescue them and make them live as long as the person who started treatment right away. And of course, any treatment, even if it's the best treatment out there will have some toxicity. And so we obviously don't want to expose you to unnecessary toxicity. And because we can salvage anybody who does need treatment when they have progression of disease, that's the rationale for not treating everyone at the time of initial diagnosis. And so that, hopefully will placate some of the anxiety that comes along with, I have untreated cancer and my doctor is not acting on it. And I just want to make sure everyone understands it's out of a lot of very good randomized clinical trial data that suggest that intervention is not helpful. And to answer the question of this patient, there are specific sort of criteria that have been listed that will prompt us to think about starting treatment, and those are very well highlighted. So if the hemoglobin is below 10 or 11 grams per deciliter because of CLL, or if the platelet count is less than 100, or if you have large lymph nodes, or if you have large spleen, or if you have a lot of symptoms from CLL, I think it's important to point out that all of these things that I just mentioned have to be from CLL. So you can have fatigue because you don't sleep very well, have depression, have thyroid issues, but that is not an indication to treat CLL, because I can treat your CLL, but if your fatigue is from something else, I wouldn't have done you any favors by treating your disease. Similarly, it's also important to remember that white cell count per se is never really featured in the indications to treat. So I have patients in my practice where the white count is 50,000, 100,000, 150,000, but they otherwise don't meet any of the other criteria for therapy. And I will say, you don't need to be treated. We can watch and see what happens. Obviously, that makes the patient very nervous. It makes me very nervous. So we watch them very closely. I might say, well, let's get your blood numbers done in about a month from now instead of 2-3 months. And so we will watch you closely. But I think we try to wait until those objective parameters are met before we start treating the disease.
So I have a question that I actually have not encountered before. And when I saw this question, I was like, I think I'd really like to know the answer to this. We live in an era of choice. We have many choices in front of us. We can choose which doctors are going to provide our care, which institutions are going to be home to these doctors. Some of us have great insurance, some of us have not so great insurance, some of us have no insurance, which all leads to the question, what are the consequences of declining treatment?
Yeah, that's a good question. I think if you do not consider that you want to get treated, I think if you have early stage CLL, the disease will progress over time. And that might be several years, and that's completely reasonable, because it might not really affect your quality or quantity of life right away. But I'm assuming that the person who's asking this question is actually at a point where they need treatment because they've been advised by their physician that it's time to start treatment, and they are contemplating, do I want treatment or do I not? I think we have to go back to data from many, many years, decades ago, to sort of define the quote unquote natural history of untreated CLL, right? As to what happens to our patients if they didn't get treated, or they got treatment that wasn't very effective, because not too long ago we didn't have treatments that were uniformly as effective as they are now. I would expect that the disease would continue to progress in such a situation where the white count may continue to rise, the blood platelet counts, which are elements that help you clot blood, may continue to decline, and that can cause significant bleeding. And it may be bleeding in places like the brain or other areas of the body that can be fatal. It can also lead to a decline in your other sort of normal immune system cells, called the neutrophils, for example, that can make you really susceptible for an infection to develop. In some patients, there can also be significant enlargement of the lymph nodes or the spleen, where you would lose weight, you would have painful lymph node enlargement, etc. So that would be sort of the natural history of the disease. It's hard for me to tell you, what I would expect with respect to life expectancy in a situation like this. If you decline treatment, I would expect it to be in the order of a few months. But again, I'm making a lot of assumptions here as I try to answer this question.
Sure. And to be sure, this is a delicate subject because people do have the right to choose. So there's a specific question about your favorite here. One of our participants has treatment that's scheduled to begin in January. Which one do you prefer, zanubrutinib or ibrutinib?
Yeah, so I think just to back up and give context to maybe other patients who may not be familiar with this, there are three approved what are called as BTK inhibitor-based treatments. These are medications that attack the CLL cell and do not allow it to proliferate and eventually kill, and they are very, very effective treatments. Ibrutinib is sort of the first-in-class medication that has now been approved for over a decade and is extremely good medication, works very well. We have treated many, many patients with this medication, and it is superb. It is a game changer, if you will, right? However, treatment with ibrutinib is given on a continuous basis, so you have to take those pills every day. And some of the side effects that happen because of daily use of this treatment include blood pressure problems, bleeding problems, muscle aches, muscle spasms, and abnormal heart rhythm called as atrial fibrillation, maybe a skin rash, etc., and several other things. Over the last sort of decade or so, there have been a lot of attempts to modify the molecule such that the efficacy of this treatment with ibrutinib that inhibits the enzyme called BTK is retained, yet some of the side effects that occur because of other enzymes being inhibited by ibrutinib are to a lesser extent with second and third generation molecules. And that's where treatment with acalabrutinib or zanubrutinib come into the picture, which are essentially the same classes of drugs, but have same efficacy as ibrutinib, but potentially lesser toxicity compared to ibrutinib. And so there are two major trials that have been done, and these are clinical trials where patients were randomly assigned to either acalabrutinib or ibrutinib, and in a second clinical trial to either zanubrutinib or ibrutinib. And in both of these clinical trials, what has become apparent is that the type of side effects that our patients experienced and the amount of side effects that our patients experienced was lower with the second generation molecules, including acalabrutinib and zanubrutinib, both in comparison to ibrutinib. And so in my experience, I have moved away from ibrutinib in a patient who I'm about to start a BTK inhibitor for the first time. If someone's been on ibrutinib for the past 5, 7, 10 years, and they've been tolerating it fine, have had no issues, I don't change. I will let them be on ibrutinib because the major reason to choose one of these newer medications is for a favorable toxicity profile or a favorable tolerability profile. And if you're already tolerating ibrutinib, then I don't rock the boat. I would keep you on ibrutinib. But for a new prescription, I'm more likely to choose one of the second generation BTK inhibitors, such as acalabrutinib or zanubrutinib.
That makes complete sense. You mentioned just a few moments ago some of the side effects of these IBS medicines. One of our participants says, can you tell me how to deal with the terrible muscle, joint, and bone pain from acalabrutinib?
Yeah, unfortunately, these are very nuisance side effects and they affect your quality of life because, you have to take this medication every day. Some strategies include lowering the dose of acalabrutinib. So in some patients, instead of doing 100 milligrams twice a day, we have gone down to 100 milligrams once a day with no big loss of efficacy, if you will, but a significant improvement in symptoms. Some patients can take intermittent steroids to help with these symptoms, although I don't think it's a long-term strategy. Some patients will try and take tonic water and some of the other sort of supplements to help with it. Again, I would be careful with those things because there can be significant drug-drug interactions. In some patients, we have been able to switch from one BTK inhibitor to a different one. So we've switched from acalabrutinib to zanubrutinib and vice versa. And sometimes we see no cross side effects. So if you switch, that side effect sometimes goes away. And the last thing I'll mention is that in some patients who've been on acalabrutinib or zanubrutinib or even ibrutinib for a few months to years and have achieved a good response, it doesn't, you can actually stop the BTK inhibitor, and patients do reasonably well for a few months to years. So toxicity related interruption of treatment is not as problematic in many patients. You can actually wait until you then have progression of disease before starting a second line of treatment. And in one of the studies, that average time duration between stopping a BTK inhibitor like ibrutinib for toxicity and starting the next line of therapy was about 2 years. So, that is another thing that you could try. And ultimately, if nothing works, then I think switching to a different class of medications like venetoclax or something else might make more sense.
So a lot of people on our Facebook support groups and other support groups have reported that they've received some joint pain relief by taking Claritin. What's going on with that?
Yeah, so I think Claritin can actually help with some of the muscle aches and muscle spasms. I don't know the mechanism of action. When we give a medication called Neulasta, that is a growth factor medication under the skin to help boost up the neutrophil count, that can sometimes cause bone aches and bone aches, and I think and muscle aches. And at that time, we prescribe Claritin, and that works. I don't know the intricate mechanisms of why it does, but if it works, it is not harmful. By all means, try it.
Absolutely. Let's shift gears for just a second. This one is striking home as well because my neighbor is actually going through an absolutely horrific bout of shingles. Evelyn wants to know, is the shingles vaccine safe as a CLL patient, both in treatment and not in treatment?
Yeah, thank you for that question. So I think from a safety perspective, there is a study that was done by our colleagues at the NCI, and I think the type and the extent of side effects from Shingrix vaccination were similar in CLL patients compared to patients who do not have CLL who got it in, as healthy adults. This was a cross-trial comparison, but the amount of side effects were similar. So there was, in the past, before Shingrix as a vaccine became available, which is a dead vaccine, quote unquote, so you should be able to get it as a CLL patient. Before that became available, the only shingles vaccine was Zostavax, which was a live vaccine, and we routinely would tell our patients, don't take that vaccine because we don't want CLL patients to get a live vaccine. But that is not true with Shingrix. So please, by all means, go and get the shingles vaccine, Shingrix. It is no worse tolerated or no increased toxicity compared to healthy adults without CLL. The efficacy of that vaccine may not be the best in patients who have CLL, but again, like I mentioned at the beginning of the program, I think your job is to just go get the vaccine and then hope that whatever amount of immune response you get is better than having zero response, which if you don't get the vaccine, you're going to get zero response.
So I'm going to slip in a question from me personally, call it the moderator's privilege. Um, when I was first diagnosed with CLL, my wonderful doctor gave me a big hug and he said, "You're most certainly going to die with this, not from this. I'll take care of the CLL, you take care of everything else." So everything else I've learned is this really tacky label that doctors put on things called comorbidities, which sounds very, very grim. How important is it for CLL patients and SLL patients to manage their comorbidities?
Yeah, that's a great question, Jeff, and I think it is a very important question. So thank you for bringing it up. I think in each stage of CLL, this is an important thing to point out. So for example, let's say you're recently diagnosed with CLL, you don't meet indications for treatment, and you're seeing your oncologist every 6 months. I'm making this up, obviously, and it's been a few years. I think what do you have to do during this watch and wait? I think we have seen that our patients with CLL
are at a higher risk of developing skin cancers. And so your job is to make sure that you go see a dermatologist or any primary care physician who does a head to toe skin exam to look for early skin cancer lesions, because these need to be removed. So that's taking care of the non-CLL part of your life, right? Because your CLL is being addressed, but everything else is put on the back burner. And I think it's important that you don't put that on the back burner, because we know of these risks. The other thing that we have seen is our patients, unfortunately, are at a high risk of developing other cancers. So colon cancers, breast cancer, cervical cancers, prostate cancer. So make sure that you go see your primary care physician on a regular basis, talk about all of these screenings, talk about the pros and cons, at least have that discussion, right? Because your oncologist is only going to tell you about your CLL and maybe talk once about, going to a primary care doctor. This is really important, because I can treat your CLL much like you got treated, Jeff, with whatever treatment is available, and those treatments for CLL have improved dramatically. But I think it's important to keep in mind the rest of you, right? What else needs to be taken into consideration? Similarly, the risk of infections. We've talked about the immunocompromised status of our patients, so make sure you get all your vaccinations done according to the CDC immunocompromised host protocol. And this is not only true in the watch and wait stage, but particularly true while you're getting treatment and in the post-treatment stage, because I think a lot goes on in the journey of a patient with CLL, particularly when they're being treated. You go through the ups and downs of the toxicities from treatment, but I think it's equally important to keep in mind the rest of the things that can go wrong, not to let those fall at a place where you forget them, because unfortunately we do see colon cancers, we do see other cancers in our patients that need to be investigated on time with a screening protocol that is recommended.
And I'll go ahead and give the shout out. You need to manage your high blood pressure. You need to manage your cholesterol. You need to manage your diabetes. Anything that is a health issue gets magnified when you're a CLL patient, when you're an SLL patient. So it's really important to stay on top of these things, to make sure that you're doing everything that you can to make sure that your body is in the best shape possible for when and if you do need treatment. Fair statement?
100% agree.
Okay, so let's talk about all this fascinating scientific research that we're doing. We are in the golden age of treating CLL and SLL. When should a patient consider a phase 1 or phase 2 clinical trial?
Yeah, that's a very good question. I think it depends on the kind of trial that is being proposed, and the stage at which your disease is. So, for example, if you have newly diagnosed CLL and you're about to start any treatment, um, I don't think a phase 1 trial would make a lot of sense in that situation. So let me just maybe back up for a minute, Jeff. Maybe people don't know what phase 1 and phase 2 trials are. So phase 1 trials are typically trials that are done in patients where you really want to see if any dose or any amount of treatment that is given is safe or not. So safety is the primary sort of primary goal of a phase 1 clinical trial. A phase 2 clinical trial is a stage beyond that, where a trial medication has gone through the safety portion, it's deemed to be safe, and now the primary focus is to see if it's effective or not. That's a phase 2 trial. A phase 3 trial is really where both the safety and the efficacy has been proven, and now you're randomly comparing this new treatment to a established standard of care treatment in a phase 3 study. And so I would say that, for the most part, so for example, at Mayo right now, in the frontline setting, meaning you have never received any CLL treatment and you do need treatment for the first time, we have a phase 3 study. So we have a phase 3 study that is comparing a standard of care treatment to an experimental treatment, but we are pretty confident that the experimental treatment will work very well. We just don't know how well compared to the standard, which is why it's been compared in the phase 3 study. But I think I would feel comfortable participating in a phase 3 study in the frontline setting. In the frontline setting, I'd also feel comfortable participating in a phase 2 study if there are compelling data to support its use, because this drug has been used in many other instances, et cetera, et cetera. And of course, this is a very generic statement, but I think everything has to be talked to with your oncologist. I think as the disease progresses, so for example, you've received first line therapy and you've had progression of disease, and then you've received second or third line therapy and your disease is now experiencing progression, I think we are more likely to take more risks to try and help your disease, right? So I think in those stages, going to a phase 2 trial or even a phase 1 trial where nothing else is available as standard of care would make a lot more sense. So I think the decision to participate in one of these trials obviously has to be made in close, conjunction with your treating oncologist. But I think in general, I would say a phase 1 trial is really meant for patients who have generally sort of completed or exhausted all the available existing treatment options, because I'm ready to take that risk of trying, an untested medication, if you will.
Gotcha. Let's talk just a little bit about supplements. We have a great question that came in from Shelley. She wants to know, are there any supplements or nutrition advice on keeping red blood cells, hemoglobin, white blood cell counts at bay? What is the role of supplements in the CLL, SLL journey?
I don't know. Is the straight answer, unfortunately. I think there are a lot of things that are out there. For example, at Mayo Clinic, about a decade ago, we had run trials looking at the efficacy of green tea extracts, for example. There have been studies done elsewhere looking at curcumin or other sort of supplements. Unfortunately, there have been no definitive trials. And what do I mean by definitive trials? I mean that a phase 3 trial where patients are randomly assigned to either a supplement versus no supplement to see if it really makes a difference. There are no such trials that I'm aware of. And so I am always a little bit cautious about saying, don't do these supplements or do these supplements, because I'll leave it up to you. You can decide. I think when you're not taking any treatments, certainly talk to your oncologist about supplements. Generally speaking, they are fine, but I'm always cautious about side effects that can occur. In some of the earlier trials with green tea at very high doses, patients experience toxicity in the liver, right? And so we have to be very mindful of these things as we think about supplements. The best advice I think I give to my patients is, think of a healthy, balanced diet, and you talk about this with your kids. You want to make sure that they eat healthy, and they have they do exercise regularly and have a positive attitude. I mean, these three things are things that I cannot prescribe, but I know that they will make a big difference. I don't know of any XYZ supplement that's going to make your hemoglobin better or your white count better or make your CLL go away. And I can't think of any supplement that's going to make things worse either that you should avoid. So I think a healthy, balanced diet, exercise as best as you can, and a positive attitude are all the things that would help you.
Perfect. Cheryl's got a great question. She's been on Calquence for 3 years. Her last flow cytometry came out with no cancer cells, and her labs are good. Does she need to continue taking Calquence? And this is a great tee up for the concept of taking the drug every day for the rest of your life versus fixed duration. So I'm looking forward to your answer.
Yeah, that's a great question. So if you follow the approval and the FDA approval for this medication, the way it is approved is you got to take it continuously. You do not stop at this time, even if there is no residual disease, because that is how the clinical trials were done. And any amount of information that we can share with you, or that was shared with you prior to your starting Calquence, that this is the amount of time you will likely experience disease-free survival, meaning you're able to, have no progression of disease, is that number is based on the fact that you will take Calquence every day, because that is how the clinical trial was done. And so we have to remember that those are FDA approved labeled indications. Now, is is it reasonable to deviate from those indications? Absolutely. But I think this is a very important conversation that you need to have with your oncologist, right? That we've looked for scans. We checked scans. There was no lymph node enlargement. The spleen is normal sized. Your blood work looks great. There is no measurable residual disease left after 3 years of treatment. And I think it's a perfectly reasonable conversation to have with your oncologist that I like to take a drug holiday and see what happens. And I think we will measure my blood numbers very carefully over time to see if the disease does come back, I can hopefully get back on Calquence and get the same type of response. Unfortunately, the problem comes is that we would then be in a territory where we cannot then advise you as to what to expect if we were to stop Calquence, because we don't have those data sets. We don't have patient information where I can confidently tell you we treated 500 patients with Calquence. After 3 years, 400 stopped it, and then in 2 years, this is what happened to these group of patients. That data is not very easy to obtain, and it's not readily available right now. So we would be a little bit in a in a zone where we won't be able to advise you very well. But I think this is certainly a conversation worth having, and I certainly feel that if you are in that situation and your oncologist is in agreement, it would make a lot of sense to consider stopping treatment and then monitoring over time.
Okay, we have a few moments left, so I'm going to ask you to open up your desk drawer just off the side of your hand and pull out your crystal ball. You know, it's standard original equipment for most doctors these days. What do you think will be the likely new approved CLL treatment that has the most promise? What are you most excited about? What do you think portends the greatest jump for us CLL, SLL patients?
Yeah, I wish I had the crystal ball, Jeff. I don't, but I will give it my best shot. So I think the treatment that is most likely to get approved is a newer type of a BTK inhibitor called pirtobrutinib, and it's again an IB, but that is an oral medication. It is a slightly different type of a BTK inhibitor compared to ibrutinib, acalabrutinib, and zanubrutinib in that it's considered what is called as a non-covalent BTK inhibitor, and that's just a technical term, but it's slightly different from the other three. And the reason I'm excited about this drug hopefully getting approved soon is that we in our clinic are most afraid of patients who unfortunately have disease progression on a BTK inhibitor followed by venetoclax, which is the other class of drugs. And these patients, we call their disease as dual refractory CLL, which means they have had disease progression on both a covalent BTK inhibitor and venetoclax-based treatment. And that, unfortunately, is an area of unmet need right now in CLL. So a patient may have gotten chemotherapy and then a BTK inhibitor and then venetoclax. And pirtobrutinib, which is this newer BTK inhibitor that is actually now approved for a different type of lymphoma, and we can actually get it off-label for CLL patients, but it would be nice to get an approval in CLL. And that medication has actually provided significant benefit in these patients who have had progression of disease on everything else where nothing else works. So I think that's, a very good medication that I hope will get approval for, licensing in the US. Another medication that I hope will get also approved is cellular therapy or CAR T cell therapy. Again, similar to pirtobrutinib, patients who have had progression on all of these treatments unfortunately don't respond very well to standard treatments, or then you're looking for a phase 1 clinical trial like I was talking about. If we have an approval for CAR T, much like we do for pirtobrutinib, that would be an important agent for us to consider in the armamentarium against CLL. And then finally, a third sort of broad type of medications called as bispecific antibodies. These are injections that are available that actually attack the CLL cell with the help of the T cells by engaging both of these together. And there are many such agents that are in development currently. And those would also hopefully provide meaningful benefit to our patients with dual refractory CLL. So if I had to pick, I would say, pirtobrutinib, CAR T therapy, and bispecific antibody therapies would all be important.
That sounds great. I'm encouraged and I'm excited because at some point I probably will need treatment again. And I am keeping my fingers crossed that you and the rest of the people who are putting so much effort into CLL, SLL research, I hope you guys get it right for me personally and get it right for everyone else that's watching and who's having to deal with this. This conversation that we've had, this has been great. I hope you want to come back and join us again. Before we close the program, do you have any closing thoughts for the audience?
No, I just want to again appreciate Jeff your time and in serving as the moderator and to CLL Society. You know, I think um, I'm grateful for the opportunity to participate in this. I hope our patients, you know, feel empowered in asking these questions, discussing this with their, you know, local doctors, oncologists, hematologists, because, you know, I firmly believe in what the CLL Society, you know, has their motto as is smart patients get smart care. And so I think it is vital that our patients be informed about all of these recent advances. And you know, I always tell my patients that you don't need treatment today, but you know, let's not talk about treatment today. Let's talk about weather, because what's true today is going to be, you know, outdone in 6 months from now, because that's the rapidity with which you know, the field moves. And I'm very happy to be able to you know, practice at a time when we have such great options for our treatment for our patients.
You are so right. It is wonderful that people have access to CLL specialists like you, because not everyone has the opportunity to see a CLL specialist in person. And I know that CLL Society goes to great lengths to make sure that people do have access to specialists and get their questions answered. So I want to thank you so much for your time and your expertise. We're very grateful for your participation. You have no idea how important this is to me and all the people who are listening in and watching what we're doing.
Perfect.
I'd like to thank everyone who joined us today. We'd also like to thank our generous donors to CLL Society and grant support from AstraZeneca for making this event possible. A few brief reminders. If you're a Facebook user, please remember to like and subscribe to the CLL Society Facebook page. Even more important, please complete the short event survey linked in the comment section on Facebook, and it will be shared with everyone who registered. We really want to hear your feedback, because filling out that survey tells us what we did right and what we did wrong and how we can do better. I would also like to encourage all of you with interest in COVID and how it affects the CLL SLL journey to join us December 5th for CLL Society's next webinar, Preventing COVID-19 and Other Respiratory Infections in Those with CLL. It's especially important during peak winter months. Our specialist will be Dr. Veronica Diaverti. If your question was not answered today, please send it to Ask the Expert email service. This is a free service and can be found on the CLL Society website under Programs and Support. Remember to follow CLL Society on Facebook and the other social media platforms. Lastly, please know that CLL Society is invested in your long life, and you can invest in the long life of CLL Society by supporting our work. Thank you for joining us. Thank you for your questions. Thank you for your attention. And thank you for letting me come into your life for just a little bit.